Hello, everybody, and welcome to today's IPC Partners Journal Club in partnership with GAMA. Today, we're going to be talking about oxidizing disinfectants versus C. diff, and Phil's going to be introducing our paper for today. Now, unusually, Phil and I are actually in the same room today at the HIS conference in London, which has been a fascinating couple of days. But Phil, I was just going to ask you, before we get into the paper, what first got you into this topic area? Because I know this is a special interest area for you around the role in the environment in healthcare-associated infection.
It was Martin Keenan. I remember seeing Martin speak at lots of different conferences, and he's a great speaker, Martin, and he really captured just how far we've come in the last 20 years in understanding the role of the environment in the transmission of some of these infections. And I think I've just always followed Martin's talks and research because he's been lucky enough to partner with people like Brett in Australia, and they've published probably the best evidence we have to date to show that the environment makes a difference. And I think that I was also interested by the complexity of it. There's so many different factors at play when we think about how frequently we clean it, what products that we use, and all those considerations you've got to make when you're using a disinfectant. So I think that ties in really nicely to this paper that we published in JHI some time ago. What about you, John?
Yeah, I mean, slightly different route in. Right at the start of my career, I started working in a field where we were looking at the role of the environment and asking the question whether and to what extent contamination on surfaces contributes to cross-transmission. And back then, when was that? 25 years ago, depressingly, the answer was we weren't sure. There was literature articles saying it probably contributes negligibly, and it's really changed now. And we consider environmental hygiene as a cornerstone of infection prevention, particularly for an organism like C. diff. Okay, let's get going with the intro then. So as with all of our IPC Partners Journal Clubs, what we're trying to do is provide some insight into a topical IPC paper, so no pressure, Phil. We're always keen to generate discussion, so please put your questions into the Q&A box. It's often the case that questions come in late in the day and it's quite difficult to filter through them, and we may miss some. So please put them in as Phil's presenting the paper. We're keen to provide opportunities for your own CPD and exercise critical thinking. Listen to what Phil says and really challenge it, either out loud or in your head to really work out whether this is real and the truth. Keen to build confidence for independent study so you can go away and feel more confident in tackling a paper by yourself, as well as building a network of enthusiasts and having a bit of fun. All of our journal clubs are made available after the event, and they're recorded in order to do so. So with that in mind, I'll hand over to you, Phil, to talk about oxidizing disinfectants and C. difficile.
Thanks, John, and welcome everybody. So this paper was something that John and I were both co-authors on. I published a couple of years ago now in JHI, and I just thought I'd start with a bit of a background to why I think the paper is so relevant in today's terms. And as John said, a big thank you to GAMA Healthcare for supporting and developing this journal club in partnership with us. So we touched upon how the role of the environment and the evidence behind it has become more prolific. Particularly for me, I'm fascinated by how long some of these organisms survive in the environment and how tolerant they are. We haven't got time to go into factors such as dry surface biofilm, which is a really kind of area of infection control in healthcare that's gathering a lot of pace. And what does that mean when it comes to choosing our disinfectants? So through the work of people like Brett Mitchell, we're knowing that the environment plays a big role in the transmission of infections, both from prior room occupancy studies right through to how more effective cleaning of shared medical equipment can make a difference in the transmission of infections and reduction in healthcare associated infections. I touched upon it in the intro as well, that disinfectant choice is really complex. We've got multiple factors. I won't go into these in detail, but these are the type of things that we have to consider when we choose the disinfectant. So contact time, material compatibility, how easy it is to use. I've always talked about you could have the best and most powerful disinfectant in the world, but if people don't know how to apply it correctly, or they apply it in the wrong way, or use the wrong applicator, then it might actually be not doing any work. And I think this is even more complex when we consider sporicidal activity, because of the physiology of C. diff spores and their biology. We know that they are a lot more tolerant to disinfectants. The other reason why I think this paper is really relevant is we looked at the performance of a lot of commonly used oxidizing disinfectants, some chlorine-based, some peracetic acid-based, but there's a real focus to ensure that we reflected real-world conditions. So looking at dirty conditions, which I think we encounter the vast majority of the time within healthcare, and reigniting, this debate around cleaning and disinfection and the difference between them and how the two processes ultimately complement each other. And I just checked out the Fingertips website as well. We've actually seen a little bit of a fall in C. diff rates recently, but there was a peak. We were going on an upcoming trajectory post-COVID. So I think the way that we tackle C. diff, knowing that it survives in the environment for a long period of time, is another reason why this paper is so relevant. So getting into the paper, as we've already alluded to, the purpose was to evaluate performance and efficacy of several different oxidizing agents against C. diff spores using a particular EN standard, 17126. EN standards can be a little bit of a minefield. There are so many of them and they assess a lot of different things. And I think the geeky microbiologist in me likes that because it gives us reproducibility, and a very strict methodology that we have to follow and a really strict criteria that we have to pass in order to claim them. But if you look at your average packet of antimicrobial wipes, you'll see lots of different EN standards. And I personally think that there needs to be a lot of education around what those EN standard means and which ones are really relevant for us. So I guess the first take-home message for anybody listening and anybody interested in how you tackle C. diff in the environment is, look at standards that are relevant, and EN 17126 is one of those standards. It's a phase 2 step 1 suspension test, and you can make 2 claims according to the organisms that you test against. So you can make a sporicidal claim if you show activity against bacillus, and I've just realized I haven't italicized bacillus, so I'm going to kick myself for that. But you can also test specifically against C. difficile or Clostridioides difficile and make a C. diff claim as well. It requires a 4-log reduction to pass, so 99.9%, and it also have the option of testing in clean and dirty conditions. But again, within this paper, we looked in both, but I think the real relevance is the performance in clean conditions. We didn't just look at efficacy, we looked at chemical degradation. So what does the presence of soil do to the performance of the disinfectant in terms of efficacy, but also stability? So does the disinfectant interfere with the activity or interfere with the available disinfectant, which is obviously the thing that we need to drive the killing of the organisms, and in this case, C. diff. The paper also looked at the difference between formulated products versus stock chemicals. So what do I mean by this? Let's take the example of peracetic acid. You can buy peracetic acid liquid or, in a powder which is activated through a chemical reaction, and it's just peracetic acid. There's nothing else added to it. We have a lot of products such as wipes or solutions where they are formulated with other things that may complement or improve the activity. So things like surfactants to give us cleaning power, maybe even the biocides. But that's a really important consideration because I'd say 95% of the time we're buying products that are pre-formulated. So I thought it was a really interesting comparison to look at how that might make an impact on both stability and sporicidal activity. I think as well, it's just really important to just point out what we mean by sporicidal. It means essentially the killing of bacterial endospores. So we're looking at a very specific mechanism here. We're not talking about vegetative bacteria. We're talking about a spore and the endospore produced by things like C. diff and bacillus. Why is that important in disinfectant testing? It's because it's one of the most difficult forms of microorganism to eliminate, because the spore provides intrinsic resistance, I guess, or tolerance to disinfectants because of its biology. We know that if we can tackle spores, we're likely to be active against the vast majority of germ groups underneath that in this pyramid of activity, apart from things like maybe prions. So sporicidal activity is difficult to achieve, But if we've got sporicidal activity, we know we've got a really high level of efficacy. So let's look at the results. As I said, we tested various different oxidizing agents, NADCC, which is a commonly used chlorine-based disinfectant. We also looked at hypochlorous acid, chlorine dioxide, and peracetic acid, and we looked in various variations of both product and stock solution. So in clean conditions, as you'd expect, NADCC and HOCL performed really well. They performed a 4-log reduction, which is the criteria needed to pass the test. However, we saw real changes when we actually added in medical dirty conditions. So adding in things that make the disinfectant, I guess, work harder and be challenged, and what we'd expect to encounter in real world conditions. That means the performance of the product started to dip. And you can see from this graph on the right hand side, I've just pointed out there 2 of the different disinfectants that we used. So you can see there on the left hand side of the axis is the concentration, so ideally really the available molecule. You can see at 1000 ppm NADCC really starts to drop off, and you've probably only got, you know, a small percentage of the actual product concentration available. Different when you have 10,000 ppm, you can see that the product concentration remains high. But I guess the big question here is use in practice. We look at using 1,000 parts per million chlorine in things like the National Infection Control Manual and a lot of our standards and guidance. So if we're using that alone without a detergent, we can see that the presence of organic matter or dirty conditions really starts to impact the percentage of product concentration. I'm going to show you in the next slide about what that means in terms of activity. So you saw major reductions in chlorine concentration after 5 minutes. NADCC at 10,000 ppm was still able to achieve that 4-pass log reduction. But again, the question here is whether or not we're using that concentration in reality. We're only really using that for things like blood spills or bodily fluid spills. We're not using it for routine sporicidal activity. And the manual, you know, claims or recommends 1,000 ppm for our transmission-based precautions. So it answers really, or unlocks a couple of questions around the need for a potential 2-in-1 mechanism, and the role really of, you know, that detergent or surfactant in allowing the disinfectant, the active molecule, to do the killing. We know that detergent and surfactant doesn't kill microorganisms, but I think this paper starts to highlight that it has a real role in allowing the disinfectant to perform. And we know really from the evidence that cleaning is a really important precursor. So I think that's another thing that comes out of this study, is the importance of cleaning and disinfection. So if we move on and look a little bit more about efficacy, interestingly, peracetic acid disinfectants showed really high stability. So they remained a lot of active material or molecule in the presence of dirty conditions and clean. Formulated products achieved the log reduction required in sedum spores in both clean and dirty conditions. But one of the things that was really interesting was this difference between formulated product and just stock solution PAA liquid. So in the presence of dirty conditions, the liquid failed to achieve the right required concentration of reduction of 99.99%, whereas the pre-formulated or formulated product, which has got other things mixed into it, actually achieved the log reduction. So I think this starts to reflect that product formulation may play a role in ensuring that products retain their sporicidal activity. And you can just see there in the graph how there's a difference between the liquid, so that's just the stock solution, just PAA, versus a pre-formulated product. And that performs well in both the minuses, the clean, and the pluses, the dirty conditions. And really interestingly as well, actually, hardly any difference in the log reduction observed in both clean and dirty conditions, so showing that PAA performs really, really well. So in terms of the limitations of the paper, I think the authors do a really good job of pointing these out. It was suspension testing, so obviously there's some limitations about how that applies into the real world. And I think that there's some future work there to do about how that looks in practice and the impact of surface-based studies and how that works for real world. it was only on one organism, but obviously we're limited to what we can test when we're looking at sporicidal activity of disinfectants or oxidizing agents. I'd be really interested to see how other organisms perform in these settings, and looking at, the emerging organisms that are causing us worries at the moment, things like Candidosoma aureus, maybe some of the emerging viral pathogens as well. We suspect that they'd probably be really susceptible to a lot of the disinfectants, because in that disinfectant hierarchy, they sit quite at the bottom, which means they're easy to eliminate. And the other thing as well is that these were in use concentrations, so they were tested at their recommended use concentrations, which may vary, and there may be things that are concentration dependent. But again, I think it's about trying to apportion the work here to real world. 1000 ppm is what we use routinely in healthcare in the UK for disinfection in the healthcare environment. And we've talked a little bit about what the study kind of refers to in terms of the importance of maybe having that cleaning step either as part of or before your disinfection, to ensure that the removal of that organic matter or the neutralization of it can allow your disinfectant to work in practice. I will say that one of the key strengths of the study really is its comparative nature. So having a real well-defined EN standard and a real well-defined set of parameters in a standardized lab setting allow us to make some really good comparative discussion points around how these different disinfectants perform, and allows us to make some really good comparative analysis between it. So what does this mean in terms of IPC? And then we'll go to our Q&A. I think it challenges our perception of some of the disinfectants that we use commonly within healthcare from a UK perspective. We've talked a little bit about that need for a pre-clean or a combined detergent and disinfectant. And I've just put up there in the top right corner of my screen, how there is this challenge around using disinfectants in practice. There's a great study by Mark where they went around the hospital in University Hospital Birmingham and looked at active concentration of chlorine within solutions that were actively being used in healthcare environments. And I think there was a tremendous range, down from maybe something like 70 ppm right through to 4,000 or 5,000. So again, we're very prescriptive about the concentration that we need. There's challenges of whether or not actually it's going to work in practice, but there's also challenges about whether or not people are making it up to the right concentration. And I've been in organizations where we've observed people, adding in an extra tablet because they think it's going to do better, or they like the smell of it, or they want to be seen that they're doing a good job. That's great, and it might improve our efficacy. But what does that mean for things like material compatibility? Does that start to damage our equipment within healthcare? I think as well for IPC, we touched upon it at the beginning, it's important to assess from your manufacturers that you have the right data. So looking at the claims and trying to help them to get you to understand, if you need that help, the importance of testing in sporicidal conditions and using EN standards such as 17126. I think as well, it's important to look at the role of products and how other things can be added to them to enhance or improve their activity. So question about whether or not it combines a surfactant as well, I think is a really important perspective, and that might be one of the differences between the liquid that we showed here and the product with the pre-formulated. The addition of a surfactant may make a difference in terms of still giving that efficacy in dirty conditions. But I think we need to do more work just to understand the mechanisms of sporicidal activity, and how these different disinfectants differ in the presence of organic matter and soil, and what's actually going on. How is the soil and the disinfectant interacting to mean that we're losing stability and efficacy? I think that's everything. I'm going to go back a slide. Actually, I'll stop sharing and I'll let John do the Q&A.
Okay, thanks, Phil. Really great session. Really enjoyed that. Very helpful and clear summary. You talked a little bit about formulation, and it's clear that the peracetic acid based approach was affected quite in quite a big way by formulation. What exactly do we mean by formulation? What is different between the unformulated stock chemical and the formulated product?
I think by formulated, we're just talking about what the product is in use and what has been added to it to essentially improve or support the performance of the disinfectant. We could talk about adding things, like I said, about surfactant, potentially even other biocides. Within a lot of the disinfectants that we use, we often see a combination of disinfectants used. I think it's really important, actually, though, that you look for what the active ingredient is. So I think that the active ingredient can tell us a lot about the performance. So we know we can group disinfectants into categories about oxidizing agents or others. So I think looking at the active, but essentially by pre-formulated, we're talking about that mix of different things which make a product as opposed to just a disinfectant on its own. So taking it away from just the stock active or stock chemical, what are the bells and whistles we add into it to ensure that it is stable, that it might smell nice, that it's not corrosive. So like the bells and whistles is the way I would kind of summarize it.
All right, got it. So a couple of questions coming in, keep them coming in the Q&A box. Does the efficacy get affected by water hardness, pH, or the presence of chlorine in the water that you might use to make up a chemical?
That's a great question. I think a lot of those factors do. I think I've certainly seen pH having an impact on efficacy, and then even with some disinfectant formulations, pH can be part of the antimicrobial activity itself. If you've got something which is extremely acidic or alkali, that can make a difference. I'm not really au fait with like the impact of things like hard water, but I'm pretty confident that it would make an impact. In terms of, again, if you're requiring an activation step, for example, in your disinfectant, what's the impact of using different qualities of water, and does that interfere with the chemical reaction? A lot of the disinfectants that we looked at in that study do require that activation step. So what does that start to do if you've got increasing levels of hardness? And I'm sure there is, again, I guess one of the flaws of that study is that we're looking at very controlled conditions. We're looking at very specific temperature. We're looking at pH. We're looking at all those factors which can influence disinfectant efficacy and stability. So I think, again, it'd be good to see how that actually translates to the real world, and talking about those challenges around dirty conditions, water hardness, and things like chlorine in the water as well. So they definitely play a role.
Okay, thanks, Phil. So EN 17126 says that it's a standard sort of formulated for the medical arena, and it's described as medical dirty conditions. But how representative is it of the actual challenge that these disinfectants are facing in a real hospital environment?
That's a great question. Look, I think ultimately we know that we have to put some challenge in front of these disinfectants. I'm not entirely confident I can answer the question about how we arrived at using those components to form that dirty element. I mean, it's erythrocytes, so it's blood essentially, but I guess we get lots of different challenges within the healthcare environment with things like dirt and dust. And I think the important thing is that we know that it's a challenge to the disinfectants, and that we're not assuming that we're working in pristine environments in clean conditions. So I'm not sure it's entirely representative of what's going on in the real world, but ultimately there's evidence, I guess, to suggest that these are the right kind of interfering substances or dirty conditions that will kind of do what we need it to do, in the sense that they will compete with the activity of the disinfectant, or they will show that need for the pre-cleaning step. And ultimately, these standards are all about standards. They are things that are designed to be reproducible, readily available, not too expensive as well, and used in a format where we can go, if we do this test in Germany, the UK, Finland, and Norway, provided we follow the standard and we keep the parameters the same, we should have a similar result. And that's what we need when we're going to do comparative testing of disinfectants. We need to have that reproducibility, that scalability as well. So I don't know, John, if you want to come in and comment on whether or not you think it's suitable.
Yeah, I mean, it feels like a bit of a least worst scenario, in that it's clearly not fully representative of the challenge that's being faced in terms of the amount of organisms that are there, the state that they're in. This is a suspension test, and that worries me, that we know microbes, when they're put onto surfaces, start to behave very differently. I wonder whether you could comment on that, Phil. I think it leads into the discussion about biofilms, actually.
Yeah, I think it's one of the limitations of the study, is that it is suspension testing. But again, we have to start somewhere. And I think that the good manufacturers out there will do the lab testing, but they will try and back that up with real world evidence. So showing about how an intervention or a change or a shift makes a difference to the parameters that we're actually concerned about and worried about. I'd love to see, more real world testing in terms of what that actually means for removal and killing of C. diff spores on a bed rail or a commode. I'd love to see more of that. But we know that we're challenged when it comes to sampling our healthcare environment and the cost and complexities of the microbiological sampling. I'd love to see a more genomic lens, within metagenomics and seeing what impact. We're starting to see that with sinks actually and drains and the impact of disinfectants on biofilm. So I don't think there's very much out there in my experience about, the role of sequencing and genomics to see what that impact that makes on the environment. So I guess my other point as well is that we know how difficult it is to perform some of these high-powered studies in IPC because we've got so many confounders. If we change our environmental cleaning product, for example, does our hand hygiene compliance and antimicrobial prescribing stay the same? So there's challenges there about how we monitor. But again, I'm really pleased to say that we are starting to see some powerful emerging studies coming from people like Brett. I don't want to keep referencing Brett, but I guess he's leading the field for me in terms of IPC and clinical trials or randomized controlled trials from an IPC perspective and looking at those interventions. So I hope I've answered your question in a roundabout way.
Yeah, no, you did. I think we're agreeing, aren't we? This test is not representative, but show me a better one. And there are some in development, and there are in future, I think, will be other tests, EN standards, that will become the gold standard for sporicidal efficacy testing. But at the moment, EN 17126 is pretty good. There are some sporicidal surface tests out there to look out for as well. Okay, so Sam has picked up on your bells and whistles, Phil, in describing what a formulated disinfectant means and said, fine, bells and whistles sounds great. It might increase efficacy, but it's going to increase cost. So is there a discussion to be had about how much we're willing to accept in terms of additional cost for a properly formulated disinfectant that works better?
It's a really good question. Thanks, Sam. Cost is such a big driver in healthcare at the moment, isn't it? Particularly within the NHS. All our organisations are trying to save money. But I guess, again, I'd point people to the literature. If you have a product that can make a difference to transmission and reduce the rates of infection, I'm saying that's the panacea, right? That's where you really want to be. And it can be really difficult to achieve that. But I guess we have to find a balance ultimately. And I think that we want to be able to ensure that we're getting good value for money, and that we're driving, value-based procurement in our organizations. We want to ensure that we've got good outcomes. And ultimately, the role of products like this is to promote and protect patient safety. We know that outbreaks of infections, more antibiotic treatment, more length of stay are bad news for our healthcare organizations and our patients, and they come with attributed cost. So, if I had a superior disinfectant that cost 10 or 15% more, I think I'd be willing to pay it if it was able to support me in keeping and improving patient safety. What do you think about that?
Yeah, I think it's a good question, first of all. But I also think it's quite open to a modeling approach, because we can model your scenario you just said. If it's 15% more effective, but 15% more expensive, but only 1% more effective, then does that translate into a cost benefit scenario? So I think that's probably something that we could ultimately model.
Yeah, maybe just one more point. I'd love to see more health economic studies. Maybe just mute John, sorry. I think that's where the landscape is going, with a lot of IPC interventions, and looking at, the real impact of some of these interventions and what does that mean in health economic terms. and things like qualies, looking at how that impacts on some of those metrics. So I think there's loads of opportunity ultimately. It's one of the reasons why I love working within this space, is that we've got evolving challenges, we've got new organisms, we've got lots of good applied research. But I think we're maybe just missing that final bit about how some of this work follows over to our real world healthcare settings, and what it means in clinical practice.
Yeah, agreed. Okay, so Ashley has just referenced in the Q&A EN 17846, which is the phase 2 step 2 sporicidal test for medical on surfaces, and whether there was a plan to kind of do the work under those. And I think probably increasingly that will become the kind of standard of care for this, or standard for testing a sporicidal disinfectant. Okay, next question from Beverly is around use cases, really, of when we might choose a different disinfectant. Do you envisage a scenario now or in the future where you might have different types of disinfectants for different applications? So you might say, if I want really high efficacy that I can really rely on in an outbreak or after transmission-based precautions, I'll use this disinfectant. But in other scenarios, I might be happier with a lower level disinfectant.
Definitely. Yeah, definitely. I think there's a human behavior side to this as well. And I think that there's something to be said about almost bringing out a high level disinfectant where we know we've got an elevated level of risk. I think ultimately it's about making sure that we're performing good risk assessments and we've got products that are suitable for, the different challenges that we face within healthcare and IPC. I personally think environmental cleanliness is one of the top IPC priorities, particularly around, some of these organisms that we know can be really transmissible, or we know that people are shedding large amounts of them into the environment, and then we think about the persistence. So I think, yeah, I'd almost like to have a little bit of a tiered arsenal approach to how we approach some of these pathogens. And I've seen some really kind of like good RAG ratings about, what we're using standard and then what we do when we step up. I guess the challenge is, though, is that I don't really see any continuity across the NHS. I see a lot of variation in the way that people apply different disinfectants to different scenarios. So we're not even going to get into automated systems like HPV and UVC, but they are one of our tools when it comes to environmental decon. And I personally think they've got, a lot of benefit and a lot of promise to some really good evidence. But the organization that I might work in might use them for CPE, whereas I might go 5 miles down the road and they might not use automated decon at all, and they might, use a PAA-based system. So I think we could do with maybe trying to just standardize our approach. And I think our corporate partners have got a role to play there. I think that, the transparency about the efficacy of their product, the evidence and the data they've got can support our decision-making tools, and ultimately try and bring, I guess the other thing I would say is that if we had a bit more standardization about our approaches, and I'm not trying to say for 1 minute that it's very different. We know there's a huge amount of overlap. But from an IPC perspective, if you're getting into the intricacies of policy about how I would use a disinfectant to do this for this organism, there definitely is variation. So maybe if we had a little bit more standardization, we could say that in those 10 organizations that use peracetic acid complemented with HPV for use cases A, B, and C, we'd have a bit more data to play with and a bit more evidence that we might be able to generate about what solutions just do what we need them to do in terms of our clinical outcomes. Because at the moment, I think that we're all trying to do the same thing. We're all trying to improve the cleanliness of our environments and provide the best and safest care for our patients. But I think that we're all doing it slightly different at the moment, and the manual is good for the guidance. But again, I'm pretty confident that most of us deviate from it in some shape or form. It does allow for deviation, but do we need to think a little bit differently about how we maybe standardize some of our approaches? And that's a very UK-centric view, but that's from my experience.
Okay, Phil, interesting. So we're going to move on to the next question. So Emma's asking about whether the choice of cloth might influence the efficacy of the disinfectant, particularly thinking about factors influencing breakdown.
Yeah, definitely something that I've looked at, not an area of my specialty whatsoever, but I think we know that substrate is actually quite important. I know there's some really good evidence out there for microfiber and how that can play, a good role in removal. Again, limited knowledge. I don't confess to be an expert. We also know that the cloth can play a role in whether or not it holds or releases that disinfectant. And I think that actually our delivery mechanism is more important, because a lot of these products unfortunately are made from single-use plastic. So there's now obviously this huge sustainability drive that I'm part of as well, to make healthcare more sustainable and remove, single-use products. I always think there will be a role for pre-formulated wipes and products because of their ease of use and their convenience and the building evidence base. But I guess the question is about how we make them more sustainable. So we can either use them more, we can reduce their use, so using them more appropriately. And I guess with gloves, there's probably overuse in certain use cases. But to come back to the question, I think that there's definitely room to try and think about what our alternatives are. But then the key thing is about how that actually interacts with our disinfectant. So does it still allow our disinfectant to work in the way that we need it to? Does it allow the disinfectant to be, released onto the surface? Does it not bind it? Does it ensure that, it doesn't interfere with the activity? And then what does that mean further down the line? But again, it's a price question. Again, limited experience that I have is that some of the more sustainable products, they tend to have a higher cost. Which is great, because we need these products and we need our healthcare to become more sustainable, because we've heard it here today, we can't go on the way that we're going from a kind of environmental perspective. But I think ultimately we need other people around the table. We need our supply chain colleagues, we need our logistics people, we need people to be able to see, if we're going to make a difference and look at sustainability and changing some of the makeup of these products, we have to have a budget to pay for it ultimately.
Okay, while we're thinking about delivery mode, there's a question from Brendan here about the dynamic between delivering your disinfectant that passes the appropriate standard using either a wipe or a dilution into a sort of bucket and then a cloth. The question was around whether there's a preference because of the role of staff behaviour, ease of cleaning, and trying to improve compliance.
Yeah, I mean, we've got different options out there, haven't we? And I think we've probably only got, you tap into the human behaviours, we've all got our preference, about what we use to apply our disinfectants. I think for me, it ties into, your different levels or different groupings of staff and what they're being asked to do. So again, UK perspective, our nurses are typically focusing on some of our shared medical equipment and medical devices. And I think wipes are probably more appropriate for that because of their accessibility and ease of use. But then I think, liquids do have a place when it comes to our bigger surface areas and the amazing work. And I really, shout that from the treetops that our domestics team do. I think they're really underappreciated area and groups of staff within healthcare who play a tremendous role in keeping the healthcare environment safe and clean. So I think, you've got different options depending on the different use cases. But I think all the things that we've talked about today in terms of the criteria for ensuring that your disinfectant is efficacious and safe apply no matter what delivery mechanism that you're using. You've probably got different risks when you think about a solution because you've got more ways in it which it can go wrong. A lot of the advantages with wipes is that it's pre-formulated, and in the majority of things you don't have to do anything to it. You might have to have an activation step, but again, that comes with challenges, and you've got to ensure that people are trained. So I think, to try and bring it all together, I think there's a role for different, let's call them presentations, depending on your use case, depending on who's going to be operating them, and depending on, how ease of use. But I guess the other thing as well is that training and education is so important. Again, you could have the best disinfectant in the world, and I sound like a broken record, but you have to train our staff. There is a science behind cleaning. We're learning it. We know. Even when I wash up at home now, I wash up from clean to dirty, which is one of those principles of cleaning, that has been embedded in me. And it makes sense, right? If I'm going to start with the dirtiest plate and I'm using a bowl of soapy water, and then all of that goes into the soapy water, I'll probably just have to throw it away and start again. Whereas if I start with clean anyway, you get where I'm going with this. So I think education and training is vital.
Yeah, I'm beginning to think you might be quite difficult to live with, Phil, but that's a different story. So good question from Lisa. Are we building a house of cards here? We're basing this entire discussion on a single organism and a single strain of C. diff. Are these findings generalizable enough to have this conversation when it's based on a single organism and a single strain?
Look, I think the strength of the paper is that it is providing evidence that we need. There's more work to be done, definitely, and looking about, how this applies to other organisms, and how maybe different strains of C. diff react to it. We talked briefly about dry surface biofilm. I'd love to see more efficacy testing done there. So I think ultimately, we've got to try and build the building blocks of our applied research and think about how that translates into clinical setting and what it means for our staff. The paper doesn't claim to solve all of our problems, but I think it does show some really interesting perspectives and creates a really interesting narrative about the things that we need to be thinking about, when it comes to our disinfectant choice, and this importance of stability and efficacy in real world conditions. So I don't think it's the silver bullet, but I think it's adding to the wealth of research that shows just the complexity of this area that we're working in, and that more work needs to be done to show about how the work that we do in the lab translates to clinical setting and what that means, in terms of how it supports and protects patient safety.
Yeah, I agree with that, Phil. And also, this paper is not standalone in that there's other papers along similar lines with similar organisms and you can see some themes coming across. So I think if this was the only paper ever written in this space, we'd be on shaky ground. But I think, it adds to some collective knowledge over decades that supports these similar themes, like the role of formulation in efficacy, the role of substrate in efficacy, the role of interfering substances, and the relative impact on different disinfectants of those things. We can look at a lot of literature that bears that out. Okay, Anya is asking an interesting question. We've talked a bit about the suitability of lab testing standards and how representative they are, but what we haven't talked about is when you get into the real world scenario, how do we evaluate effectiveness day to day? Can we do that? Are there effective ways that we can measure effectiveness of a disinfectant?
That's a great question. So I think the first thing I'd say is that the work that we're presenting here today is about building our foundations about how our disinfectants perform in the lab and highlighting really what those challenges are. In terms of how you assess the performance in the lab, in the real world, we touched upon it earlier, actually, talking about, the need for maybe new ways to assess. So we've got our basic microbiological sampling, where we go and swab a surface and send it to the lab and see what grows. Traditionally been used a lot, but obviously lots of drawbacks. We don't know what we're going to be able to culture. What happens if I swab 5 centimeters to the left? Does that give me a completely different result? Time consuming as well and quite costly. Got things like ATP, which I think work really well to give you a really quick qualitative view about how your level of microbial energy currency essentially changes after a surface has been cleaned. But again, can be quite expensive, but a good educational tool to show that if we do wipe a surface, ultimately your ATP levels will go down, which shows that you're removing the bioburden. I think there's a lot to be said for qualitative work, ensuring that if we've got products and disinfectants that we know perform well in the lab setting, how does that translate across into the clinical setting in terms of my ease of use? Does it improve the compliance scores in my environmental audit, for example? Does it mean that my equipment was cleaned more frequently because it was easier to use the product or it was easy to access? So I think from a microbiology perspective, I would love to see some studies that on surfaces now that move towards maybe the more genomic application, and what's happening to those organisms and giving us a much more holistic view in terms of the communities of organisms that are there pre and post disinfection. But I also think there's some like really interesting human behavior stuff to do, because I think we could do a better job of optimizing the disinfectants that we know perform well in the lab and how that translates into the clinical setting.
Okay, Phil, we've got time for one more quick question. So this is from Emma, and it's nicely worded. I'm going to read it out verbatim. Products, disinfectants. Do you think our biggest problem is the overwhelming product selection that come with different methods for use, rinsing requirements, contact times, etc.? Feels like we're setting up very busy clinical staff to fail.
Yeah, it's a really good question, and it's a really pertinent note to end on. I think that the market is not flooded, but there's certainly a high density of these different products for, like you say, different use cases. And I touched upon it earlier, there's the EN standards can be a bit of a minefield. I think even me, for somebody who's worked in the decontamination space for nearly 15 years, is that I have to often check, what that EN standard is designed to do, and the test organism and all the different parameters, etc. And it's an evolving space as well. So I think there's definitely a role for partnership between healthcare and industry, in my opinion. And I think that industry actually can do a good job, provided that the credentials of the company and their approach to education and training is a good one. I think that we can learn from industry. We've got companies that have good work that's being done on their R&D pipelines and understanding efficacy, and I think we can learn a lot. So I guess the thing I would say, that if you're looking at evaluating disinfectants, what do you want? You want good efficacy, you want good data, ideally peer-reviewed, published, and I think ultimately you want good training and support. So you want people who are going to come and educate our staff. I think the other point, just to touch on recent, is that healthcare professionals, I wouldn't expect a nurse in ITU to be able to tell me the difference between this EN standard and that. I think that's our role as IPC professionals. We're the ones who need to kind of review that evidence and inform ourselves as best as possible to say, this is what we're looking for and why, this is our use case and this is why, and how that filters down through the organization, again, is our role. But I think there's a role for our corporate partners to play in supporting us with that, and things like this as well. So hopefully everybody's learned something today.
Well, I certainly have, Phil. And actually, that last question links nicely into the Delphi consensus group that we're working on at the moment. So we're looking to develop a framework, an evidence-informed framework for disinfectant selection and evaluation. That if we have a fair wind, we're hoping to premiere some of the findings at the Infection Prevention Control Conference later in the year. So look out for that. Okay, next up we have Dr. Luke Moore is going to be presenting an insight webinar. So this is in partnership with the Healthcare Infection Society and the Infection Prevention Society on AMR and CPE, impact and interventions. And I cannot wait for that. And finally, all of our journal clubs and insight webinars, the schedule is available on the website, and you can subscribe by clicking this QR code in order to hear about upcoming events and the latest updates. So all that remains for me to say is a very big thank you for joining today, and on behalf of IPC Partners and GAMA, thank you very much and see you next time.